So I think we'll get started. So Kinexikoe, hello relatives. Natanako Jason Dean, Namoto do Amskapi Bakuni. So Jason Dean, professor of medicine in the division of cardiology. So welcome to the second UW Medicine Center for Indigenous Health Visiting Native Professor professorship. It's my very great honor to introduce my good friend and colleague and mentor, Dr. Dorothy Rhoades. She is a community-based researcher that addresses cancer in American Indian communities. As a member of the Kiowa Tribe of Oklahoma, Dr. Rhoades earned her medical degree at the University of California, San Francisco School of Medicine, and her MPH in epidemiology here with us at UW. So Dr. Rhoades is the director of the Native American Center for Cancer Health Excellence and is a professor of medicine at the University of Oklahoma Health Sciences in Oklahoma City. She's in the division of general medicine. So her work addresses cancer prevention, screening, and access to care for tribal nations and citizens. So please help me welcome Dr. Rhoades.
Oh, thank you, Dr. Dean Jason, for the privilege of coming here to provide the grand rounds today. And I appreciate everybody's turnout. They own de Batsan in my language. That means it's great that you all have come. Goima Ada, I'm a Kiowa woman. Doyama Goikan is my Kiowa name. It means medicine woman, roughly translated. And so I've got a lot to cover. I will kind of go pretty fast at this point. And if you need to have me slowed down, just kind of go the timeout route. What I want to kind of focus in on is how we developed the program. So I've had a lot of people kind of wondering, how do you build not therapeutic, excuse me, I'm speaking from a medical point of view, some partnerships that are effective in working with tribal communities and addressing something that is of concern to the communities, and cancer is one. So I have no financial disclosures, and the objectives that I had was to kind of give the very brief overall view on cancer disparities, then discuss some of the principles that have guided our work in the past 12 years or so, and that is the principles of bidirectionality and sovereignty and how that promotes research partnerships, and then focus a little bit on some collaborative care as it applies to the cancer arena, since a lot of cancer is done in cancer centers and is not something that an Indian health facility can provide on their own and has to be referred out. As you all probably already know, the coordination of care between primary care and oncology is an issue throughout our clinical system. Um, just in case anybody here is going to want to develop research partnerships that they haven't already, these are not, this is not super breakthrough information here, but it's just the basics and just the familiarization with the population, understanding what is their cancer health status, and understanding the healthcare landscape of the population, because it's not quite as easy as you would think or you would expect going through training. What you see is not quite the same as what would be out there in what we sometimes call as Indian country. So in terms of the nomenclature, there's no universally accepted term. So I might use any of these terms and maybe even other ones to refer to the pre-colonial inhabitants of this continent. And so for tribal sovereignty, which governs everything that we do in terms of our research arena, is just a reminder that this is a political designation, not necessarily a racially defined designation, and that there is legal rights to healthcare services, as you can see, based on treaties, court decisions, acts of Congress, executive orders, and other legal bases. So this is the basis of all work that we do, that understanding. And just talking a little bit, understanding our population. So population in Indian health system. And these numbers here about like the 6.3 million, it kind of depends on how you're counting who is or who is not American Indian Alaska Native. That's the term that is used by the federal government when talking about racial categories. So I'll use that a lot. But about 6.3 million alone or combined with another race, you might see higher figures from other sources. You might see lower figures. It just depends on how the census is adjusting what they do frequently. But this is probably even already out of date. I think now there's 575 federally recognized indigenous sovereign nations that we will also kind of refer to as tribes across the United States. And the population that is served by the Indian Health Service, the tribal health system, or an urban Indian organization, what I'm going to call the ITU healthcare system, is close to 3 million people with, as you can see, 14 million outpatient visits. And the resourcing of the Indian healthcare system from federal dollars, as you can see, is not even quite 1/3 of that for the rest of the nation. So these health services get this much smaller bucket of funding for a huge array of health services, and that directly affects the delivery of cancer care. And that's why most ITUs cannot provide their own oncology providers. They can't afford them, and the services have to get referred out, at least as of now. And so some of the brief overview of the epidemiology of cancer. The good news, I like to start with some of the good news, is cancer mortality is decreasing over the past 2 decades for all races and all sex. So that is the good news. The disparities kind of strikes here still that for American Indians and Alaska Natives, the overall cancer incidence rate was the highest of all the racial and ethnic groups. This is for the data that is limited to those counties, those areas in the country that are so-called designated PERCTA counties, as purchase and referred care delivery areas. The Indian Health System, the IT system, has to establish boundaries in terms of who is eligible for those services. And I'll show you a map and you can see where the PERCTA counties are next. But in these areas, the cancer incidence is highest among the Native Americans compared to the other major racial groups in the country. Cancer incidence is increasing among the populations that had not previously been quite as affected, as we know from young children, adolescents, young adults, whereas it's been going down in the white counterpart across the country. And the cancer mortality among the American Indian Alaska Native population is the second highest in the United States, exceeded by African American Black. So kind of looking at a lot of these, I got to step back here. Let me know if I can't be heard. Um, for the different lines there in terms of what's been happening over time. Because as you can see, the incidence rates kind of trying to climb up, mortality rates kind of going down. Am I seeing this correctly? By gender. So sorry, guys. I probably should look up here to see how things have improved, yet the disparities remain significant in the United States across time. But I think these trends here, for these trends 1 to 2, these are significant changes in that uptick. And so also looking at the age standardized for all sexes by race, just comparing with the other races, you can see here, let me get this guy out of the way. This line will kind of show you where the Native Hawaiian American Indian Alaska, non-Hispanic American Indian Alaska Native in the PERCTA counties is. So it does come up a little bit higher than the non-Hispanic whites, and you can see the comparisons with the other groups. And this is the nationwide data, and you can see it's from the 2020 data. And looking at the healthcare system, the ITU. So the shaded counties are the PERCTA counties. And ITUs, just as a quick brief 101, were designed to deliver direct care services, and a lot of this is the primary care. Somebody comes in with cystitis, that can all be handled within that ITU facility. If that cystitis or thought to be somebody's having a little hematuria and they get worked up and they're found to have a Goomba in their kidneys, that's the official medical term for you third years. It's for that cancer. Well, that's something that cannot be taken care of by most ITUs, and they're going to have to refer that out to contract health services. So specialty care is what is defined by these PERCTA counties. So if I needed to get treatment for cystitis while I'm here visiting in the Pacific Northwest, I could go to any IHS facility and get that direct care. If I'm diagnosed with a cancer, I can't get that cancer paid for from this facility. I have to go to my county of residence and hope that it's in one of those that is covered. So that's kind of in just a little nutshell. and I'll try to give you the overview of how we're doing it in Oklahoma. So Oklahoma's American Indian population is the second highest in the country by sheer numbers, and it's estimated that we have almost 634 that are American Indian or Alaska Native alone or in combination. The vast majority of Indigenous people in Oklahoma are American Indian. It's also the second highest proportion of the population that is American Indian or Alaska Native, meaning we have almost 16% of the population is American Indian Alaska Native, either alone or in combination. Even alone, it's 9%, which is relatively high. We're second to Alaska in terms of the proportion. We're second to California in terms of the the absolute numbers. And just as a reminder, there are 39 tribal nations in the state of Oklahoma. I stole this slide from the First Americans Museum in Oklahoma City, which opened just recently a few years ago. And it's just an illustration of all the rich and varied cultural traditions in among Oklahoma's American Indian population. So I'm going to take a quick poll, and this is just kind of think in your head. So cancer incidence mortality among Oklahoma's American Indian population exceeds that of the non-Hispanic white counterparts by about how much? I think 25, 50, 75, 100%. Any guesses? Okay. It is about 50% higher. And you can see how high these rates are compared to what I showed you for the nation as well, and how much it exceeds those of the other races in Oklahoma. And it's the same situation for mortality, also about 50% higher than the rest of the population in Oklahoma. So that's a lot. And one thing to note, in Oklahoma, our rates of cancer are among the highest in the nation. So Native American rates are even higher than the state of Oklahoma's already high rates. It's actually 49% higher, but okay. And at the cancer health disparities, they start at barely, you can see they're already starting at relatively young ages, and they just keep going, both for incidence for American Indians compared to non-Hispanic whites, as well as the mortality. As you can see, that they break off mortality a little bit later, but the incidence just goes continuously, almost completely throughout the lifespan. So we've got a lot to work on there. Oh, I'm sorry, I think I went backwards. And looking at the leading causes of cancer mortality, so I'm just going to skip to mortality. And you can see the differences. So Oklahoma has one of the highest rates of lung cancer in the country. We have high rates of smoking in the state. And you can see how much the lung cancer mortality among the native population exceeds that of the Oklahoma counterparts. This is just within our state. And you can see some of the disparities also. Even if the absolute numbers aren't really high, you can see how much more we have in prostate cancer, for example, 0.7 higher in the mortality rate ratio. And you can see some significant disparities that also are the leading ones, those top four, the lung, prostate, breast, and colorectal. But also when you look down, pancreas, kidney and renal, and others, we have some major disparities. And so some of these, as you saw, those leading causes of cancer death are screenable. And the rates of the cancer screening in the American Indian and Alaska Native population, take yours on whether it's higher, the same, or lower than in the general population. Yeah, this was a hard question. And yes, it's fairly significantly lower. So breast and lung cancer screenings, this is talking about American Indians, Alaska Natives. This is more nationwide, not just limited to Oklahoma. And it was below all race and ethnicities combined for cervical, colorectal, and prostate cancer screening. And looking at the situation in Oklahoma, so over here you see the rates of breast cancer screening. The Oklahoma American Indian Alaska Native population compared to the others is here in the blue. And for Oklahoma, we actually slightly exceed that of our non-Hispanic white counterparts. Oklahoma has a breast and cervical cancer detection program that it's had for several years with an active tribal buy-in. And we think that this is reason why we have achieved some sort of parity, that we actually have slightly better screening rates for breast as well as cervical cancer. Colorectal, not quite so much, and prostate, not quite. We don't have any special programs for these. And lung cancer screening rates, as you know, across the United States are pretty poor. These data are probably getting a little old here, but very low in Oklahoma compared to even the other Oklahoma population. So in terms of taking some of this information, how do we engage the community and how do we partner with the community to address some of these problems? And so at the Stephenson Cancer Center, they're pretty devoted to cancer research and outreach. The Cancer Center is relatively young. It was established, it opened in 2011. And very soon on, the Cancer Center director said, well, we need to be addressing cancer health disparities in the Native population here. So that was always a concern for those. And that's, I was actually living in Seattle before my partner, Mark Dosher, who is the Associate Director for Community Outreach and Engagement now at University of Oklahoma. We were recruited from here to go back to help establish this cancer health disparities program. And doing so, we had to make sure that our institution was devoted to respecting tribal sovereignty, the data sovereignty, and that as much as possible, we engage the community. And the even best is actually have partnerships with the community who are actually part of the team designing and implementing and discussing the findings and interpreting the implications and disseminating the product. So I think our COE was very active. We really tried to grow the program quickly, and we achieved our NCI Cancer Center designation after just a few years of opening, and got it refunded in 2023. We're going to try to go for comprehensive, and so we are ambitiously trying to continue to grow our program here. So this might be pretty familiar to everybody else, the principles of community-based participatory research. You can see from the original words from like the Nina Wallerstein, who is the goddess of CBPR, and basically means, get to know your community and engage them and get their input. Their knowledge is important. That's related to Indigenous knowledge. I think they're very closely related. Indigenous knowledge is just recognizing that we don't know everything in the academic realm, and understanding what things are like in the actual community. You have to know what that is in order for you to be effective in whatever you're trying to research and any improvements you're trying to do to the health status. So there is also very well established history of misbehavior, whether intentional or unintentional, by researchers when working with Native American communities, with tribes, whether it's even just with their data. And a lot of that research is also not showing a direct benefit to the communities. And this has gone on for decades. So tribes have exerted their sovereignty, and they say, we are as interested in improving the health status of our population. In fact, probably more so than the academic researchers who come in. But this research needs to help us now, not theoretically sometime in the future. We have problems right now. And it just takes one episode of a breach of trust, whether it's intentional, unintentional, and the entire research enterprise could be affected because tribes understand. It goes through the grapevine, and you hear about something that a tribe was disrespected. Other tribes are going to know about that and potentially withdraw their support for research. So what we've been trying over the past several years with our community engaged research has been fairly successful. This isn't limited to just biomedical research. We kind of, as we were compiling our successes, related to our community engagement participatory research since 2015 for 10 years, brought in 44, extramurally funded awards across the spectrum, research, education, and outreach in Native American communities. Spent at least $58 million through that. We have involved more than 30 tribal nations or tribal organizations with our partnerships, and there have been full partnerships with tribal nations, or tribal or urban Indian organizations, as well as some 6 tribally led Native enrolled schools. So this is where we are really trying to make sure that there's partnerships as well as engagement. So this is kind of how the work that I did. I'm only kind of limited the work that I've been involved in. There is other work here, and I feel remiss for not putting it all there, but we don't have time. And I told her to cut me off because I could just keep going. So there was no funding for cancer health disparities research. There was just our time, our FTE, and getting established. So when we came to Oklahoma, we said, we're here, we want to work on cancer health disparities. We kind of made some reach out, made some connections. And one tribe said, oh yeah, we've been noticing something that we want to address. And it was skin cancer in their population. And that's something that is not high on people's radars when they're talking about skin cancer in Native populations. So we did unfunded study in full partnership with the tribe. And we had simple surveys that we sent out to the youth. They had youth advisory councils that we administered over 100 anonymous surveys about their tanning habits. And what we found were sky high indoor tanning rates, as well as outdoor tanning rates among the white counterparts, but higher among the Native students. And so we took some of this information and it made it to the tribal newsletter. And Mark Dosher had taken this information to the Oklahoma legislature as they were considering indoor tanning beds, and so provided some of this information. And there was legislation was enacted to ban minors' use of indoor tanning. And it also kind of during that period was, well, let's get these sunscreen out into like the U.S. parks. So like at the zoo, they established a bunch of sunscreen dispensers there. So that was one example where we went in, we said, what do you want us to help you research? They said this, we got the answers, and it went on to meaningful change statewide. We tried to leverage this to get a nice big R01 out of it, but we were brand new, and the reviewers were like, you've never done this. You're talking about we wanted to work across health systems. You're unproven, you're untried. So we were unsuccessful. But as we were looking through, we worked with some other tribes who said, I also said, I'm kind of interested in these emerging risk factors among adolescents and Native Americans. Vaping was coming up, and I was looking through the vaping literature after we got there. There was nothing, well, virtually nothing on Native American use of vaping products. And I said, well, we've got the highest rates of tobacco use in the nation. What's happening with vaping? And so we did the same sort of thing. Really, I tried to get funding internally, didn't get it, but he said, go ahead, do this project. So on my own time, developed a survey, administered across a lot of Indian Health Service sites at their health fairs, their youth fairs. And we found that we had the highest rates in our little communities of vaping use among middle school as well as high school students compared to the historical data that was available for other populations. And we joined forces then with another large tribe in Oklahoma that said, well, we're interested in looking at this. So we applied for a P20 grant to help enhance the research capacity of our tribal partner. And we were looking at the use of vaping among adult American Indians who smoked. And we found high rates of vaping, and we tried to explore multiple different facets regarding that. But we found that it was mostly dual use. People over time, it was a longitudinal study, had not really stopped smoking. And their biomarkers for use, we did do urinary biomarkers of nicotine. They did not change in the people who had vaped, who were dual users. From those who smoked, and also their cigarettes per day didn't go down. We did not find it a benefit. And there's been a subsequent research that suggests that vaping may be a harm reduction, but you have to completely get off cigarettes. Otherwise, it's either no better or possibly even worse to have dual use. So that was one of several other aspects that we worked together with. This was a direct partnership with the tribe, and got several papers out to look at different aspects. We looked at depression. We looked at some of the factors that went into the use of vaping for the adults. And we also used some of this information, preliminary data, that got the researcher with our tribal partner a grant to study smokeless tobacco use and the impact of vaping and other the potentially reduced exposure products. And there we were finding that there was dual use as well. It didn't seem to be affecting the use of the the smokeless tobacco as much. And so then that led to um, another P20 where we expanded what we were looking at. So we were looking at the effects of vaping among American Indian pregnant women, as well as the smoking cessation among American Indian cancer survivors. So we are actually in the process of kind of getting these papers written up now, because that recently finished. But this is just sort of an example of how it grew. And again, this was full partnership with the tribe. Approvals before we submitted the grant, the tribe says, yes, we want to endorse this. IRBs means we have tribal IRB, we have our institutional IRB. These are factors that other researchers aren't aware that there is extra time that has to be factored in when you're building these programs. There are a few tribal IRBs in Oklahoma. There's 3 of the tribes have their own IRB. Other research that's done with Indian Health Service facilities or their data is the Indian Health Service IRB. So some of these that had across the ITU, we had tribal health IRBs, we had Indian Health Service IRBs, we had our own IRB. And so it takes a lot of time and a lot of patience, but it is worth going through those steps. But we also noticed that we wanted to be committed to this bidirectionality. It's not us saying, hey, you need us to study vaping. It was hey, we didn't say, hey, we need to study skin cancer in your community. We need to see what the youth are doing. They told us, and that's what we helped design that. Excuse me. And so I've just put here, there's other research to support this kind of model. I'm just giving you an example of how we implemented that with our studies. We tried to have community advisory boards whenever possible, when feasible. If our direct partner was the tribe itself, that is their advisory board. And it's sort of interesting sometimes with people trying to be respectful of research in what I'm calling Indian country is the tribe and our facility working together. Well, where's your community advisory board? Well, that's the tribe. This is what the tribe wants. Well, where's your community advisory board? It's just like, it's not just a checkbox. You got to realize who you're working with. So that helped us make sure that we get the community advisory board so that you get the guidance of how you conduct your research. But as our research grew, so was interest in research with the Native American communities and their data at our institution. And we were finding people were saying, oh, that's pretty cool. That's pretty neat. I've got a bunch of data. I want to see what its situation is in Native American communities. And that kind of concerned us a little bit because we know that people who are not familiar with the communities will sometimes do research that is perceived as not beneficial or harmful to the communities, and that perception is often correct. So some research can result in community harms. And we emphasize in the work that we do with people, if they haven't had experience working with tribal communities, to make sure they do this minimum amount of training to realize that there's community harms as well as individual harms that you must consider when creating research. So that led us to incorporating Indigenous knowledge in a more formal way. And we created a tribal advisory council in 2020, specifically to say, you guys need to help. I can't be the gatekeeper for the research here. We need community input. So we created the Tribal Advisory Council to look at how we might advise the Stephenson Cancer Center to handle the data that they have. If we are working with a tribal partner within that tribal community, the tribe oversees what we do. If we're working with Indian Health Service and we want to use their data, they oversee what we do. The data that is at the Cancer Center is not under the jurisdiction of a tribal nation. It's not under the jurisdiction of the Indian Health Service. It's under our jurisdiction. And we wanted to be careful that we don't misuse these data and break the trust that we've been building with our, not just the research community, but patients at our Cancer Center. So that was very helpful as they helped guide us gave us little ideas about things that we could do to make sure that we keep this bidirectionality open, and led to some additional grants. And so this demonstrated to our leadership that it's worth establishing the Native American Center for Cancer Health Excellence, which we'd been talking about for a couple of years before, but we finally got it all formally done in 2023. And that was wonderful. We'd actually come out there kind of thinking, wouldn't it be great if we had a cancer center that was devoted to, a center within the cancer center devoted to Native health. And so that's our NACHI, our Native American Center for Cancer Health Excellence. And as we try to grow, and I think I tried to shove too much on the slide, sorry, but basically our mission is we want to do right by Native communities, not just in research, but we want to see what we can do to even branch out further to make sure that there's access to care, educational pathways for Native communities to go into the health sciences, to go into cancer research, pathways for non-natives to also help address cancer-related issues in Native communities. And this, it's not limited to oncology, can be obesity and factors that would lead to obesity that will lead to cancer down the line, and anywhere to the whole spectrum. So we weren't really limited in what we wanted to look at. We did want to focus on our priority cancers. You saw those huge disparities in mortality and high rates. Even if they weren't high disparities, they were high rates. So with the TAC, we'd also say, that's great, we've got you all here. It's about roughly a dozen community, tribal health leaders, other indigenous organization leaders, and kind of said, well, what do you think our priorities should be? And they said, you got to take it to the community, duh. So we developed a survey with our Tribal Advisory Council, an anonymous survey that we took out. It wasn't an epidemiological study. We would go to, events, community events, and we'd ask people, what do you think our priorities ought to be at the Cancer Center? And of these 11 items, those that were rated most frequently rated, the extremely helpful, were early detection, screening, cancer prevention, and communication between cancer care and primary care providers. These emerged as those that were ranked as the highest, or ranked as extremely helpful compared to the others. So as you can see, genetic ancestry studies of cancer was not a high priority of the community. The research community outside of Native communities for the past decade has been really hot on this, thinking that there's some magic gene that's going to be uncovered. That's just probably not the case. It'd be lovely if that was, and we could kind of fix those genes, so to speak. But this is what people wanted to have done now, because the problem is right here in front of their faces. So that kind of led us to make sure we were building partnerships that would be of direct benefit to the community. So we were building implementation partnerships. So we received some funding, and we being some of these were me as PI, but others were me as a co-investigator. I'm just kind of presenting what we've been doing collectively. So we got an administrative supplement to our Cancer Center grant to see if we could improve colorectal cancer screening across the ITU spectrum. So we had Indian Health Service, we had a tribal health program, and we had an urban Indian program, and we worked with them. We met with them, say, what are you doing for colorectal cancer screening? We all wanted the rates to go up, and found out what each was doing at their own site, asked how they would want to improve this, and they had some just wonderful ideas. So, COVID was hitting, and they were having the drive-through vaccinations. We would have these flu fit drive-throughs, or COVID flu fit. So they'd get their injections, and if they were of eligible age, they got a fit card to go home with them. Another tribe said, well, if you get your fit card back, we're entering you into a raffle. Natives love raffles, at least in Oklahoma. So they had some very, very innovative ways that we didn't think of. They thought of it, they implemented, we helped them. And we also got funding for lung cancer screening, the tribally engaged approaches to lung cancer screening. When I went to Oklahoma, I was like, I wanted to get some lung cancer screening. I wanted to study that because I knew it was the leading cause of cancer death. My own personal background is I'm a clinician. I'm an internal medicine physician, hospital-based. I've only done hospital medicine since 1997, so primary care scares me, but don't let that scare some of you off. And the other parts were doing some research. Can you all hear me? I've got interference. Am I rubbing against something? Okay, I'll let them troubleshoot. Thanks. So anyhow, for those of you who might be junior investigators or might be thinking about research, again, I myself, my research had been somewhat limited to secondary data because I had not given up I practiced here in Seattle for 50-60% time, hospital-based work. Didn't leave a whole lot of time to develop research with a capital R. So when I came to Oklahoma and tried to apply, got a R01, said, I want to look at lung cancer screening within across the ITUs. The reviewers reasonably said, where's your previous experience? Where's your preliminary data? Where's the proof that you've worked with these communities? So I tried twice. And on the third time, we actually said, okay, let's get our implementation scientist as the PI. My electromagnet. Did somebody find? Oh, you found it.
Got it.
Okay.
Nice.
And it was.
It was one of
It
the
was-
students' left.
Okay, so we got, the experts who had implementation science. By this time, by our third attempt, we had other demonstrated the ability to work with tribes. And so this got funded. It was a 5-year project that just finished last year with a large tribal nation in Oklahoma to do lung cancer screening. You saw the rates of lung cancer screening that were like 6% in Oklahoma. After the study, it has gone up, and we think that they might have single-handedly increased the rates of screening for the state of Oklahoma because they've done thousands now. And this was like a navigator coordinator within their own health system to see if that would work to improve lung cancer screening rates. Also got some funding to improve the Native American navigation program that we had at the Cancer Center. So when the Cancer Center was established in 2011, there was also direct tribal buy-in. So they received generous donations from 2 large tribes, and they said, well, we want this money to specifically for our patients' referral process because it's so hard to be referred from an ITU to specialty care. And so those were our navigators. Now navigators would refer often to clinical nurse navigators, oncology nurse navigators. These are not nurses, but they understand the ITU system, and they help us improve the access to care through the navigation program. And we were trying to enhance that. And this was an example where I was going for the grant. I went to the TAC and I said, they want us to look at these metrics, including clinical trials education. And they said an optional metric would be going into actual enrollment in clinical trials. And the TAC says, we think clinical trials education is important, but we think it should be bidirectional. You need to educate your researchers. You need to educate your providers. And we said, oh, duh. And we did that. And we delivered 2 oncology grand rounds at our institution on the cultural perceptions of research from Native American patient perspectives. And an oncologist who hadn't had previous experience with Native American community says, why don't we know this? We should know this. And she created, using institutional funds, to create a program, an online program for medical students, residents, and fellows for them to complete online, discussing some of the things that we had discussed in that grand rounds, and found that they, on their Likert scale, they were moving up an entire point in terms of their understanding and their comfort of working with Native communities. So that was how our discussions with that indigenous knowledge that kind of stated the obvious to us, that you need the bidirectionality, has resulted in improvements at our cancer center. Uh-oh. It's not responding to me now. Someone turn your mic back on.
Yeah, oh, you got it.
Okay, thank you. Was that just one slide? Okay. Yeah, okay. And I'm kind of jumping ahead. So I'm kind of showing some of the progression. So you heard like that, this first arrow up here, how our lung cancer screening in this tribal health system, that first trial that just finished last year that we're collecting on, it helped inform us and get us the experience that we got a second grant that is currently funded. It's starting its second year, lung cancer screening in another tribal health system. Also mentioned that colorectal cancer screening that we had done. It also led to another supplement because we were finding with both of these screening projects that the screening rates went up. Fantastic. We said, okay, great. What's happening with the follow-up, and are we actually making an impact? And the follow-up went from, the screening rates went up, the follow-up was stayed way low. So there was a drop off, and it's like, okay, our navigation, our coordination is going to have to see how can we get from the test to the diagnostic workup. And that's what this supplement was for, to find out how we can improve that follow-up for the abnormal screens. This experience also led us to further screening that, is a top priority of our community, is we are an access hub site for the nationwide Vanguard trial. The Fred Hutch is the data coordination center for this multi-center trial of the blood test, the multi-cancer detection assays, where, they're testing how well these are going to perform. There's a feasibility trial in terms of the blood tests for cancers, for multiple cancers. We don't know if this is going to actually cause reduction in mortality. We don't know how well these screening tests are going to improve upon what's already existing, but it seems very hopeful and promising. So there was a lot of buy-in from our communities in Oklahoma. And so we have rural health facilities, we have federally qualified health centers that are participating, and we also have tribal interest. So one thing that has taken us a little while, we've already in the field, they've screened now about 200 people. We just opened it up in Oklahoma, and we've been working with a large tribe in Oklahoma for several months, and NCI and with the Hutch, to make sure that we can get a protocol that meets the needs of our potential tribal partners. And this was in their tribal IRB did initial review and said these are some things that are non-starters for us, which we thought would be. For these large multi-center trials that NCI funds, you get blood samples, they store it, and they can use it indefinitely for whatever purpose or future studies. Usually for a lot of Native communities, if they don't know you, they don't trust you, they don't want you to have their blood stored away for some unknown future study that they will have no say in. So there are other studies like the Strong Heart study, which Dr. Dean and I are both part of, which I haven't really had a chance to discuss here, has been collecting samples for 3 decades, basically. And this is because every time we use those samples, they have to be approved by multiple tribal sites, because this is a multi-site study. The specimens have even been blessed by local traditional healers. And so we show respect for those samples, and we make it clear that access to those samples is limited. They have to be vetted. But some of these larger funded trials that are not focused on Native Americans don't have that limitation on them. So we have been working, and NCI and the Hutch have been very helpful in working with us. They're very willing. They say, we really want these tribal communities to participate, and we're just about to get this finalized so that we can get this out in the field to our tribal partners as well. And so you've heard me talk a little bit about navigation and care coordination. So here's another poll. So patient navigation kind of provides the logistical and supportive guidance to patients throughout their cancer journey, and it can improve outcomes. So has this been studied in Native populations? So this is kind of a poll that navigation and care coordination have been shown to improve which of these outcomes in an American Indian population? Oh, this is an easy one. Yeah, you should have me writing your test questions. But yes, yeah, that it works. So we also mentioned about our navigation program that we have here. Our cancer center is the only one we know of in the state of Oklahoma that has a specific coordination program for Native American patients. There are a couple others across the country, but there's not a lot. But we know that navigated patients have these improved intermediate outcomes as well as absolute outcomes. Oh, I've got 10 left. Oh, okay. All righty. Well, good thing I talked a little bit about our navigation services already. So even though there's 39 tribal nations in Oklahoma, there's a lot of tribal people there. So people we have had patients with more than 65 different tribal affiliations that have been navigated through this program, probably going on nearly 5,000 since the inception of it. That's a large number in the Indian community, especially for cancer related care. The REACH, the navigation program, we did this from about 18 months of patients who were coming in. We got the zip code data, and it is statewide. So they're coming from across the state. And this can be hundreds of miles. So this is a 4-hour journey from way down here. Some of these other hubs are where we get some of the more frequent referrals from in terms of the Chickasaw and Choctaw Nation, some of the largest tribes and largest health systems within Oklahoma. So that's our statewide reach. And cancer care coordination is important. I don't know if I have to convince you all of that. Here's more details about some of the work that we did with our navigation that to enhance the capacity. One of these included what we wanted to be care coordination. And this was from one of our native navigators. As we were doing a financial hardship screening, implementation, and other things, looking at how can we improve our navigation program, she was the one who said, well, we have these huddles in the hospital. I don't know if you all have them here, but sometimes there's team huddles where multidisciplinary talk about a patient, say they need this, 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 and this. And we wanted to apply this to the cancer care. So we did pilot this. We had 3 huddles with a referring tribal health clinic. And this is actually public, the patient's papers just have come out. And we actually have a commentary in New England Journal of Medicine about our care coordination that looked at that. At first, there was a little hesitancy because we're taking their time. You saw the resources are limited in tribal health systems. So you're asking someone to take on an additional duty. Our hope was that these huddles would reduce. It wouldn't be an additional duty. It would be in place of the ad hoc calls that had to be done. So there was a little bit of, there was both high buy-in, yet the people who had to do this were a little reluctant because this might be extra work for who knows what benefit. But after just those 3 trials with just a few patients, there was enthusiasm for this. So that helped us apply for more funding to further improve our care coordination. And we applied for U19. There were 2 sites that were funded. The Fred Hutch was another one with Dr. Nelson, who is the contact PI. And so this is ours. Ours is called ICON, Improving Cancer Outcomes in Native American Communities. These are the multiple the multiple PIs. I'm the contact PI. And this is our second lung cancer project that I mentioned. We also have one where we're looking at cancer prevention. Again, our second highest rated importance on our community survey. And this is looking at heavy metals in the water and seeing their association with incident cancers. And also taking that information to try to help the communities regulate their own water. If they don't like how much arsenic or uranium is showing in there, is there something they can do about fixing that? And then also our care coordination and communication program in oncology, C3PO, that's Dr. Nips, brilliant icon. And this is care coordination where we're building on the huddles. Instead of just supportive care, Dr. Nip is actually going to be an oncologist, he's a medical oncologist, he's going to be on these huddles so that if there are additional questions about here is a symptom somebody's having, or that, could he be as a conduit if there's a clinical question? As I was mentioning earlier about some of the coordination care, what if there's like a Lupron injection? Can it be done at an IT or does it have to be at the cancer center? And this is what we're hoping that these huddles will do. And these are some of the outcomes that we are hoping to see. We're just starting our 2nd year and hoping that our pilot implementation will begin. We're aiming for next month. It's January, February. Yeah. And we have a lot of indigenous knowledge embedded in this. We have tribal health advisors from 3 different tribal nations that are a part of the team. A lot of the investigators have experience, and we've got letters of support from the ITUs so that we went to them before we submitted the grant and they are interested in participating. And the collaborative care model, let me just cut to the chase because we're getting further down. A little over 5. Okay. Well, collaborative care, there's good evidence that it works. And this is kind of how we're looking at collaborative care in our settings. So the usual care was that that happens in oncology as a patient in the ITU facility. It diagnoses that cancer and then refers them to the cancer center. So the ITU facility, the patient, the oncology team. So here's some of the modes of communication. Here's where we got our navigator that can help coordinate some of those. We want to actually further close the loop where we come here, where the oncology team, the navigator, and the ITU facilities, they are talking about the problems that this patient is facing. So it's kind of modeled kind of like a tumor board and kind of a huddle. So it's kind of a combination of those. And then we're going to be collecting several points of data for the participants of these and how we kind of communicate with them. See, I don't think I have too much. So again, this was just, we've tried to incorporate all these principles. I guess I'll hit you over the head over how much that you have to work with the communities. The NIMHD funded this U19, the National Institute of Minority Health and Health Disparities. And we also used their research framework that looks at some of these different factors that affect health. For Native populations. Over here, you can see some of the things that we wanted to keep in mind in our framework as we developed the project. And we also base this on what's known as the REAIM framework for implementation science, where you look at the reach and the effectiveness and all down to the implementation. We're also concerned about sustainability. That's something that we want to make sure. So we kind of think in our mind REAIMs that sustainability additional to this, and we're hoping that we will find a way to do that. So this is more details about our project and who gets navigated and some of the information regarding that. We're collecting qualitative information from providers at both ITUs and the Cancer Center, as well as patients about these to help us kind of design our study, our pilot implementation. Once we do the pilot implementation, we'll be doing exit interviews to find out what worked, what didn't, what needs to be added, and there will be in real time adjustments to how we implement these huddles. And then once we finish this open pilot, then we'll have a randomized controlled trial. Well, we'll go to, we have one ITU facility now. We're going to roll it out to 6. So we're going to be covering quite a lot in the future. And this is just how we envisioned how they would work in the RCT. Their standard of care that they're already getting with the navigation program, we already think is a higher standard than is found at other places that may not have this liaison between the two health systems. So, okay, good. Summarizing. So as you can see in those, at least in those PERCTA counties, if you look at nationwide data, you got to be careful what the source of the data is. If you just look at nationwide data across the US, it's not limited to the PERCTA counties. It looks like the cancer mortality is less in the Native population than in the general population. But a lot of those are not, the ITU system may not serve a lot of those. So in those states where you didn't see the blue boxes. And then also how we built our cancer center and tribal approaches to improve outcomes, just those steps again. This is not, earth-shattering science, but it's the implementation to make sure that these steps are followed and that they guide people as they go through. And the key one is just this bidirectionality. It will improve your study. It will improve your work. It takes more time, but it improves your work and is worth doing. Okay, I hope that means thank you in Kiowa, and I guess we now have time for comments and questions.
Unmute.
So we're unmuting some of you. Okay.
Yeah, thank you, Dr. Rhoades, and thanks for to the Department of Medicine for helping us collaborate on this visiting professorship. I think we have time for maybe one question. I think Dr. Rhoades will mill around afterwards as well.
We do have a question in the chat, well, a few questions, but I think I'll pair to pick some of the ones that are more relevant. So one person is asking what should Dub providers know about local Native American populations, and are there any resources that you can point us to learn more?
What's that? The Center for Indigenous Health is a fantastic resource, and right here, Dr. Jason Dean would be. Yeah, he's the first person to call. No, that's just one. Yeah, but I don't. Do you want to say a little bit about what you do?
The center is a ecosystem building center through the UW Medicine. So yeah, any questions, please direct them to me.
And Millie Kinney,
And
right
yeah.
here, she's an expert.
Yes.
She has a legal background, so she also knows a lot of that. I'm speaking for you, Millie. Okay.
All right. Well, thanks everyone for coming. We would like to end with an honoring of Dr. Rhoades as our visiting professor. So, if you so the presentation of a blanket is a very traditional way to honor someone in many Native communities. It basically is a symbolic kind of wrapping of our arms around the person to be honored. So, we really appreciate your time and expertise with us today.